What the hell was that?
That was a Persian teacher.
Board certified reproductive endocrinology and fertility specialist, Canada and the US, and now much of Europe, because we get tons of patients from Europe and all over the world. So welcome to the show. I do know that one of our viewers, who Tarek and I have come to love, is watching from Germany at 3 a.m. So for the young lady who is watching, thank you for watching. We try not to use your name, although you're welcome to. Love that you watch at 3 a.m. And you know what she actually messaged us? She said, we were the most exciting part of her week, which I feel terrible about. We need to find a way to make your life more exciting.
I think this is a good show. No way. This is my excitement of the week.
This is your excitement? Mine too.
A lot of people get excited on Tuesdays.
I love this
We're
show.
like Seinfeld on Thursdays or Friends on whatever day it was. Like, where's the show?
I love the show too, also because my new kitten only loves my wife, and so this is my way of getting at least some enjoyment out of my life.
That's it.
The kitten loves my wife exclusively.
Hey, Dr. Rahi from Australia. So people want to know it's not just Germany.
You know what? As you guys come on, tell us where you're from. That would be awesome. Let us know where you're from. Just send us a message about I am from wherever. And please remember that Tarek has monopolized how to ask questions by choosing them based on the number of likes that you throw. So you will be condemned for not putting up enough likes.
It's just friendly competition.
It's just friendly competition.
It's just friendly competition.
You know, when we first started the show, it was all about acknowledging him, but now he just wants to like. So tonight, no great papers out for me to review with you guys. So it is another show about answering your questions. However,
London, England. North Carolina, USA.
London, England. That's like 1 a.m. for them.
It's a great show.
That is crazy. Thank you for watching, guys. So
San Francisco.
San Francisco. Oh, cool. Yeah. You know, California, we always have a big following out in Cali. Yeah.
Amelia and I love watching you. So there's a lot of people. Windsor, Ontario, of course.
Ontario. There you go.
Leamington. Leamington's in the building.
All 40 minutes south of us. So no great topics this week. So we're going to answer your questions, like I said. But we do have a video coming out very soon on myths about birth control use. So that'll be a cool video. Hopefully you'll enjoy that. And we also will have a video about our endo protocol, which lots of people have asked for. I did put up what I thought was quite a hilarious post about the little baby laughing on Instagram for people that are getting estrogen as part of their fertility protocol or frozen embryo transfer protocol when they have endometriosis, which obviously makes no biological sense. That baby is super, super cute. And so it was perfect. And I just merged the two together. It's still going crazy. It's kind of one of our more viral videos. And lots of people had comments on that. So we figured we'd just share our protocol with everyone. And so we're going to create a video for that shortly as well. Tarek and I will be busy on Sunday. And we're going to start a whole other channel because we're both addicted to chocolate. So we're going to start a channel about chocolate. So we'll see how that goes. And we'll go from there.
Fort McMurray.
Oh, Fort McMurray. Very nice. Very good. Cool.
And Toronto, of course. Toronto's in the house.
TO is kind of cool. Yeah, for sure. We got lots of patients from Toronto. A lot of our patients actually come to us from Toronto. Everybody's originally worried, like, how's it going to work? You're so far. But we monitor you in Toronto, and then you just come to us for retrieval and transfer. So we've got bucket loads of people doing that because, A, we're probably better, and B, we're cheaper. So it's kind of a good combination to have. And we are definitely personalized. I don't believe in, cookie cutter medicine. And we will have a post probably after Sunday on my complaint about fertility care for patients because I keep getting patients that are just getting care I cannot understand. Like, it literally makes no sense to me. So I think I'm going to rant a little bit and see if you guys like my rant. So we'll see.
See, you are way better. I was about to say that. You said it kind of a little bit better. I would agree. Way better. Way better. And some from Mississauga. We got some Mississauga here as well.
We just had someone on TikTok ask us how many times they could get AIDS.
There you go. That's a great question.
Well, AIDS is not a specific condition necessarily. It's when you have HIV positive status and then you get a specific disease that defines you as having AIDS. Kaposi sarcoma, cervical cancer. There's a whole laundry list of them. And so you could get something that qualifies for AIDS, obviously more than once. So I'm not sure if that was a serious question or not.
You got a lot of new kind of questions.
All right, no problem.
Hi from Italy.
Someone countered that one and said AIDS isn't used anymore. Yeah.
What do you mean AIDS isn't used anymore?
That term. They don't use...
Oh, they don't use that term anymore?
No.
Oh,
No.
there you go.
Yeah, although I'm no infectious disease specialist, so...
I am less so.
You are less...
I am less so.
Hello from Italy.
Hello from Italy.
Wow, hello from Italy.
Shall we begin the questions?
Yeah, for sure. Fire away.
Okay.
Hello from... Let's take Italy.
Let's take Italy.
Yeah.
My question is...
We got to get the Europeans to sleep.
Keep them up, man. Keep them up. It's a party. This is an international party.
Woo!
My question is...
Yeah.
If before an FET and during pregnancy, we can do a facial treatments with lasers and Botox injections.
Oh, laser, sure. Botox, no. Botox has long-lasting effects and it shouldn't be used close to a pregnancy, so don't do that.
I'm just reading.
The whole HIV thing is going crazy.
I
Yeah.
never, to me, this is all new information.
Nobody says AIDS anymore. Yeah.
So it's HIV? That's what it is?
Yeah, HIV, and then you can have diseases that used to classify you as having AIDS, but it was very pejorative, so they don't use that anymore.
Gotcha. Hello, Dr. Victory and Tarek.
Hey, there you
Obviously, that deserves
go.
some love. Absolutely. When do you use the different washes? PRP, HCG, Neupogen. Big hug from Munich.
Oh, wow. Munich. Wow. I love Munich. We were just in Munich, actually. Beautiful city. So, for PRP, depends on what you're using it for. There's two uterine uses for PRP. One is to thicken the endometrium, and one is for unexplained failures. So unexplained failures, you want to take it 2 days before. Lining thickening, you're supposed to take it sometime before, like 5 days a week. But I actually think most studies are now supporting the idea that it can take a month. So we actually do it like a month before we're going to do the embryo transfer. Neupogen, if you're doing it into the uterus, it's again useful for unexplained failures. So we use it for that. And typically the study said 5 days before. So we do it 5 days before your embryo transfer. And then HCG is used for failures as well. The meta-analysis that we actually reviewed on the show probably a year and a half, 2 years ago, showed that 15 minutes before the embryo transfer is the time to do it. So that's what we do. 500 units, 15 minutes before. And it does have to be done properly because when you're drawing up the HCG and you pull it into the syringe, you have to preload the syringe with enough air to clear your catheter. Otherwise, you're just flushing out air. You're not getting any of the HCG in. So it has to be loaded properly into the catheter. So depending on which catheter you use, the physician or nurse, whoever is loading it, has to preload the syringe with air, then pull up the HCG, then connect it to the catheter so that when you push in the HCG, the air pushes in behind it and flushes it out of the catheter. So we do it 15 minutes before. There are studies that have tried all sorts of different things, but we do the 15 minutes. It does seem to work, so I do like it. It's cheap, it's effective, it's easy to do. It's not painful or harmful in any way. So yeah, we're fans for sure.
We don't need sleep. You're worth it.
Aw, that is pretty wicked.
All right? We don't need sleep.
Best comment we've probably ever had. That's pretty awesome. Yeah.
East Africa.
Thank you for watching. East Africa.
But living in the USA.
Oh, okay.
But from East Africa.
But from East Africa.
Yeah.
Wow.
That counts too.
That counts too. Yeah.
Convinced. This is a question now. Convinced.
Yeah.
My doc to do a letrozole FET.
Oh, cool.
Convinced.
Okay.
I just want that to be
in there.
That has to be in there.
Yeah.
Trigger was required for scheduling.
Okay.
He does not recommend double prog, PIO plus low dose HCG is what my RE settled for. I also convinced him to test prog on day of ET, and 3 days after, levels were at 240 nanomoles per liter on both days.
Woo!
Was that too high?
Yeah.
I'm feeling super dizzy.
Yeah, that's way too high. And the dizziness is coming from the fact that high doses of progesterone are they're like an anesthetic. You can actually use it as an anesthetic. So don't do that. And that's way too high. It's very excessive. So if they triggered you for timing, they had to counteract the effect of your natural progesterone production by decreasing what they were giving you. So we have to titrate it. So you definitely should be bringing down your injectable progesterone for sure.
She goes on to say, what are your thoughts? So you already gave the thoughts.
That dessert is so irresistible. You are eating it in the middle of the show.
You know what happened? I took a bite and I don't know what happened. It just couldn't stop. I couldn't stop.
All right.
Also, what are the chances for an unexpanded 4BB? My clinic adds a minus to its grading system, embryo to implants.
A minus? Never heard of that before, so I can't really answer that question for you. Did I buy the limited edition? I don't know what a Temu Rose toy is. Do you know what a Temu Rose toy is? Should we look that up? I'm a little terrified.
You should be terrified. Who knows what that means?
I don't know what
the guy's name is I Got Banned.
I Got Banned, yeah.
Don't look up anything he says.
That's a great TikTok handle, by the way. I Got Banned. Endometriosis advice. I'm only 29, so I'm trying to be able to preserve.
The answer shows up if you scroll.
Oh, does it?
Yeah.
It's an adult toy. Did I buy the limited edition? No, I did not buy the limited edition Temu, whatever that is. So I'm trying to be able to preserve my fertility with endometriosis. So endometriosis, if you're trying to preserve your fertility, make sure you don't develop endometriomas. Try simple stuff if you're just trying to hold off the endo. So birth control pill, Vizan is really helpful. Oralisa with Adbac would be next, and then Lupron with Adbac after that. Surgery if you have cysts, because if they're getting bigger, they are doing damage to your ovaries. So that's something I would definitely advocate for. There's 5 supplements you can use: NAC, coenzyme Q10, curcumin, resveratrol, ALA. There's some other ones as well, but those are the main ones. And then the bigger issue for you is, should you preserve your fertility by doing egg freezing or embryo freezing? And at 29, there's probably not a huge amount of pressure to do so, but it's probably worth getting your fertility checked. So AMH, FSH, your thyroid, your ovarian reserve, antral follicle count. Take a look at what your uterus looks like. Has it already sort of folded over from the endo, or is it still anteverted, anteflex? So yeah, there's some things you could look at to figure that out. I love that Carly answered the question. That's quite cute.
As long as we don't have to look
Love you, Carly. Hope you're well.
Do you recommend to completely stop breastfeeding before a transfer? Can you also say how egg retrieval hormones can affect milk supply? P.S. You are the best.
Oh, I'm definitely not the best. I'm just someone that tries really hard with Tark. Yeah, you cannot do an embryo transfer while breastfeeding, and you cannot do stimulation while breastfeeding. It won't work. I actually just spoke to someone the other day who had tried and had a disaster cycle, and the fertility center told her that it would be fine, which is ridiculous. So you cannot try doing an embryo transfer or a stimulation while breastfeeding. Your high levels of prolactin while breastfeeding will suppress your estrogen response. So in the uterus, that has a hugely negative impact. But even on your ovary, it does provide relative suppression, which is why breastfeeding is definitely not birth control, but it is harder to get pregnant when you're breastfeeding. So don't breastfeed and try and get pregnant. It will not work. We actually make all of our patients stop. Not that I discourage breastfeeding. Huge proponent of breastfeeding. Breast is best. Everybody who can should breastfeed. But you shouldn't do it if you're trying to get pregnant. That won't work. Yeah.
How many IUIs would you attempt before moving on to IVF? Had one successful pregnancy which ended in a blighted ovum in February, unable to get pregnant again.
Depends on her age. So less than 38, up to 6 is considered reasonable. Over 38, 3. So we do those. We stick to those numbers. It's from a Chinese study that we reviewed on the show a couple of years back, which showed that above 6 in the under 38 category, the chance of success was 0. And above 3 in the over 38 category, the chance of success was 0. So those are the references I give my patients when we're talking to them about what to do.
What is the success rate on first FET with a 4BB embryo?
Well, it depends on a whole lot of factors. So those are always the crystal ball questions I cannot answer. It's impossible for me to tell you what your level is or your percentage is going to be, because I need to know, is it genetically normal or not? What's your body mass index? What was the sperm quality like? Do you have endo? I can't answer those sorts of questions. It's impossible. I can tell you that in our hands with a genetically normal embryo, our success rate is extremely, extremely high. It's over 80%. So we do very, very well if it's genetically normal. And certainly a 4BB genetically normal embryo would give us that kind of result. But I need to know everything about you to give you a better estimation. If you have endo, if you have uterine damage, was there scarring in there before, are there infections, what kind of protocol are they using? Like all of that stuff is super important. Yeah.
When in an IVF pregnancy do you find out the gender? At 20 weeks or earlier?
Well, if you're doing NIPT, you could do it via that, and then you can find out anytime after about 9 to 10 weeks. But if you're doing it via ultrasound, there's an ultrasound technician I have, and we're trying to get together a study to see if she's right or not, who believes she's figured out a way to tell at 12 weeks on ultrasound. And without getting into specifics, she calls it the angle of dangle, which I haven't fully understood, but there's something she's measuring which she thinks distinguishes boy versus girl.
The dangle.
The dangle. But if you otherwise are just going for your routine ultrasound, that's at 20 weeks, like 18, 19, 20, 21, 22. So somewhere in that 18 to 22 range, they should be able to distinguish the gender of the baby, the sex of the baby. Sorry. Wrong terminology. Yeah.
Dear Dr. VNT.
Yeah.
Which vaginal probiotics do you recommend we take along with the antibiotic treatments for chronic endometritis?
Oh. So we use one called Flora from NFH, but I don't ever support one product over another. So anyone that's good is fine. And especially with something like probiotics, I don't really think it's going to make that much of a difference, guys. The key is to flood yourself with it. So as long as you're getting lots oral and vaginal, that should do the trick. TikTok has gone crazy. Are you catching these?
Yeah, I got them all. Okay. But they're you just got very minimal likes on TikTok. So
yeah, that's true. Yeah, there's one like.
Yeah, they need if they really want to get an answer.
If you want your answer, you better start throwing up the likes.
We need some likes here.
I did warn everybody. Yeah,
they didn't take it seriously.
Oh, that was not what I wanted. Okay,
all right.
I started letrozole this month, and I've still not ovulated cycle day 16. Yeah, I mean, letrozole can be delayed till 17, 18 sometimes. Occasionally, it'll stretch out your cycle, but it doesn't always work. Like some PCO women just don't ovulate on letrozole at a 5 milligram dose or a 2.5 milligram dose. Sometimes you have to go higher. And there's one study that showed that if you failed after 5 days of use, if you extended it for 10, a high number of those women would end up ovulating. So I think it was 97% of the women that failed the 5-day dose actually did better on the 10-day dose. So you could try that as well. Yeah, don't worry about that. And then CK told somebody else you can see him anytime. We used him for IVF and had a baby in February. Yes, you can see me anytime. Not actually anytime, because my office will kill me if I say that, because people will be calling saying, he said I could see him anytime. So you can't see me anytime, but we'll get you in as quickly as we possibly can.
Her question was, hi, Dr. Bakery, do you require couples to try for 12 months before seeing you, or can we come before?
No, I mean, it depends on your history, right? So first of all, it's broken down by age. And then second of all, it's broken down by regularity of your periods. So if your periods are regular and you're less than 35, it is very reasonable to try for a year. Now, if you have special family history or a time crunch, or your mom went into menopause at 36, yes, of course, come and see us, because we want to make sure that's not going to happen to you. So you can get your fertility potential assessed at any point. If you are irregular in your periods, you should be seen at any time, like right away. Don't wait, because that's a risk for cancer. And then if you are over 35 up to 39, you should be getting in within 6 months of trying. And if you are over 39, they recommend just 3 months. Arguably, I'd say, just come and see us to optimize everything right from the get-go.
I'm just trying to figure out where to read from. Is it true? Great question. Is it true you're more likely to have a girl with ICSI?
It's been looked at many times, and I've looked at all of those studies, and they're not consistent. So some of them says ICSI increases the risk of having boys, and some of them say that ICSI increases the risk of having girls. I have seen more studies that favor having boys from ICSI. I can't tell you that we're seeing that in clinical practice, because we basically ICSI almost everyone, because our success rates are so high with the ICSI, and we're not seeing a specific ratio of boys to girls. So I think it doesn't make a difference in our practice, but certainly the scientific literature does not support anything either, because it's very discrepant. There's some studies showing one, and there's some studies showing the other, and then there are some showing no big difference. If there is a difference, it's minimal. We're talking about 3 or 4% preference for one or the other. It's not like 2/3, 1/3, or something like that.
All kids are good kids.
All kids are good. I hope my kids are all watching. Yeah.
I said it.
Yeah. Tarek's 5. They're amazing. My kids, meh. I love you guys. Yeah.
What is your opinion?
My kitten sucks, but everybody else
You know what? Fully reasonable comment. What is your opinion on euploid day 6 and day 7 1cc embryos, and it's a specific Create fertility grading scale?
Oh, well, a 1cc at Create is a good quality from the 1 number, because theirs is the opposite of everybody else's. The cc would definitely be concerning. But I do know people that have had cc grade euploid embryos at Create that they were successful in having a perfectly happy, healthy child with. So I think there's a chance. Is it a great chance? Probably not. The research would support that CC graded embryos have a lower chance than B or A graded embryos, but there's still a chance. With regards to day 7, the literature definitely says your day 7, even euploid embryos have a much lower chance. So the highest number I've seen was 15%, regardless of the grading. And then if it's a CC graded embryo day 7, I would be very concerned about using that embryo. But a day 6 CC, I mean, obviously that's not the top quality embryo, but would I try it? Of course I would, before I made you spend all that money again to do more IVF. Yes. Yeah. There's always hope as long as you've got an embryo. And euploid is huge. So if you've got a euploid embryo, it's got a chance.
Hi, Dr. V.
Hello.
Thanks for helping me out earlier. I have a follow-up question.
Okay.
Would a period be normal on the 3rd Lupron depot injection? Also, would this affect lining for baseline?
It can be. Some women just break through the Lupron. So it's not uncommon to have people that have periods on Lupron. So that's pretty commonplace. As far as will it affect the lining? It definitely should not. No, not at all.
I'm 43 years old.
Okay.
With low AMH.
Okay.
And high FSH.
Okay.
Been trying to conceive for 4 years.
Oh, okay.
4 IVF failed.
Oh.
And now my period's not showing for 2 months.
Okay.
Anything to do to bring my period back?
Well, you don't want to bring your period back. You want to adjust your ovarian reserve. DHEA can help. Testosterone priming can help. Human growth hormone priming can help. PRP does seem to be supportive. I redid my lit search on PRP over the weekend. There's a expansion of a previous study which had about 260 patients and now has 540, and they are showing benefits. It's small, it's very modest. It actually went up from what they originally showed, so there is hope for it. So we've been doing it now for several months. And I do believe in the PRP thing. I think it does have a benefit for some patients. So yes, I think that's reasonable to do. There are lots of people doing something called NPLAF, where they let the PRP sit to release cofactors, and then they take that as well. I don't understand how that makes any difference from injecting the PRP, because if the cofactors are coming from the PRP, what difference does it make if you inject PRP or inject the cofactors and the PRP? They're together anyways. But people are doing it. There's certainly no evidence for NPLAF. There is a study out of one university where they are researching it now, but there's no evidence for it yet. So it's just another gimmick until we know better at this point in time. But those are the only things we know of that can kind of rejuvenate the ovaries. There is a well-known fertility center that claims that things like an ozone sauna and electromagnetic fields can, or pulsed electromagnetic, irradiation of some sort can actually make a difference. I looked it up. There are 2 studies, and they are both authored by the specialist that is offering the service. So that's obviously not ironclad, and they were not randomized controlled trials. So we don't know about stuff like that. I mean, I'm not trying that until someone shows me solid proof that it works. The best evidence for anything that is going to rejuvenate the ovaries is actually giving women AMH, the molecule, which has been tried, and there was like a 20% boost in your ovarian response and reserve when they gave you AMH. But there's one guy in particular who I met at a conference in Belfast in the wintertime last January, who is doing research on a synthetic AMH molecule, which he said tripled people's egg yield. So he's working on that hard and fast, and that could be a breakthrough for everybody, but it's years away from being available. So that'll be super interesting. I am kind of tempted to see what's involved in that, but this guy's a genius scientist, and he's going to do well. So we'll see what that shows.
Hi, Dr. V. NT. After a lap for endo, do you do letrozole every day for 3 months along with Lupron?
Yes, definitely.
That's an easy.
That was an easy. Yeah, it was a gimme. I thought the cramps here. Let's take one from here. I thought, I missed it. What did I just do? I thought the cramps were a good sign of ovulation nearing, but nope. It can be. It depends on what kind of cramps you have. There can be bowel cramps, bladder cramps, kidney cramps, ovarian cramps. It all depends on what's going on. Is starting baby aspirin once you find out you're pregnant too late to have any benefit? No. It's probably reasonable at preventing preeclampsia, and it probably prevents preterm labor, Carly, so it's not too late for sure. Am I still offering satellite monitoring at IVF Canada? Yes, as well as tripod, and we can use Create also. I have special arrangements with 2 of those. The other one's more expensive. I won't mention which one's which out in public because I don't want to disparage anybody, but you can contact us and I'll go through it with you.
Here's an interesting question.
I'm okay to rant about the fertility centers because I won't actually name who they were.
There you go.
So when we do the video, I'm okay complaining, but I never want to disparage any one center.
Of course.
Yeah.
Not the style.
Yeah. Even for the one that actually told people they didn't have time for them.
That was my favorite line.
Wasn't that crazy?
That was my favorite line.
I hear some bonkers stuff. I heard one today. I had a patient that came in today and told me their story, and it literally, it actually kind of makes me angry that people aren't getting the care that, it's all just, hey, let's plow them into IVF. And I'm like, why are they, where's the answer? They don't even know what's wrong with them. This couple had recurrent pregnancy loss. They hadn't figured out what was wrong with them. So they said, what's wrong with us? We don't want to just do IVF. And they're like, oh, it's just coincidence. 4 previous pregnancy losses. Coincidence. 2 with heartbeats. There's a less than 2% chance of a miscarriage after you got a heartbeat. Wow. How can a fertility specialist say that? It's just like irrational. It makes no sense.
Shame.
It makes no sense. Like, get people answers. Then you can offer them options and then let them choose. Don't railroad everybody into IVF because you want to go on a fancy trip or buy a nicer whatever. It's crazy. It makes no sense. I hate that.
I got a question for you that we've never heard before.
Oh, fire. I love the challenges.
I think you can.
Do I need a drum roll?
Hell of a reason to drum roll.
We need like a synth thing here, and I can push. Like,
oh yeah.
applause.
Get ready.
Yeah.
Does masturbation cause weakness in sperm and morphology?
No. Ejaculation in general is a good thing, whether it's through intercourse or masturbation. There's no evidence for alteration. Now, if you're excessively masturbating, yes. So I remember when I was in med school, someone told us about a guy that used to masturbate. No, he and his wife would have sex over 10 times per day. I don't know how you even manage that much time. And then she would catch him masturbating.
Oh, wow.
10 times a day, and she would. So yes, that'll kill your sperm quality. But if you're once a day or once every 2 days, there's no harm on sperm quality.
10 times a day. I'm just
trying
to understand the time.
That was the wrong moment for me to look at you.
Because I'm trying to. I have 24 hours in a day.
10 times. I mean, I don't know. Maybe you had premature ejaculation or something. Can you imagine having sex 10 times in a day?
No. No, I can't. I cannot. I don't think anybody can.
That's a lot of nookie. Yeah, I don't.
It's a hell of a question to ask.
How do you have that much time? I'm freaking busy.
I don't think anybody has that time.
I love my wife dearly, but she'd kill me.
10 times.
10 times.
Hell of a number.
And then the wife caught him masturbating. On top of that, like, that's kind of an obsession.
There's something going on there.
There's something going on
there. We barely get it every other day, some people say.
Okay, you know what? We should throw up a poll. Can you put up a poll? What's an appropriate frequency of intercourse if you weren't trying to have a baby? Because for having a baby, it's every day or every 2 days nonstop. We know that. But if you weren't trying to have a baby, what's a reasonable frequency of intercourse?
Put it as a comment. I'll read them out.
Yeah. Put them up as comments. Tell us what you think. Just shoot us a number. 1, 3, 5 per week, right? So number of times per week.
Yeah, I'm quite curious what the numbers are.
I am curious. Let's see what the team says.
That's a great question, Dr. Victor.
That's a good question, isn't it? Yeah. What's the next question on TikTok?
I was hoping to see some numbers.
Once you're pregnant, but you're older, 38 plus, are we considered high-risk pregnancy? No. Your age does not make you a high-risk pregnancy. It's your risk factors that make you a high-risk pregnancy. So you are at higher risk of developing certain conditions. So if you're over 40, your risk of preeclampsia, gestational diabetes, stuff like that, you're at a higher risk of developing those, but that doesn't make you a high-risk pregnancy till you have them. Would I take extra precautions? Of course. Baby aspirin, sugar control, weight management, all of that stuff, of course. But I wouldn't jump into calling you a high-risk pregnancy just because you're older versus younger.
You got numbers showing up?
I do?
Yeah.
All right.
You have some people saying 4 times?
4 times a week.
3 to 4 times a week. You got other people?
3 to 4 times, yeah.
You got ratios here. 2 to 3 times per week.
Okay.
3 to 4 days per week.
Yeah, same, yeah.
People are doing about 3 to 4 times a week.
That's pretty good. I can tell you that is probably higher than normal.
I think these are all very young, energetic individuals.
I hope. Well,
I think
if they're up at 3 in the morning and
these
you're
are all very
energetic individuals.
I think these are energetic people.
Yeah. Yep.
2 to 3 days a week. 2 to 3 days a week. Yeah, I think they're energetic.
2 to 3, 3 to 4. When we have low AMH level, does it mean that I'm going to miss my period soon? It can. When your AMH level is less than 2 picomoles per liter, you are headed towards menopause, and it's only a matter of time before you stop getting your period. So yes, that is a possibility.
They're looking for clarification. Is this before, with kids or without kids, this number?
Oh, yeah, that's a good one. Yeah.
I'm of the opinion it should always be the same.
It should be always the same.
It should always
the kids
be the
never
same.
made a difference.
Well, they tried to. They tried to.
Yeah, it's we could ask both before or after.
Yeah.
Yeah.
Just extra effort.
And you got to be
It's
quiet.
a lot of effort.
Yeah, there's no more noisy sex.
Yeah.
What are the studies on methyl tetrahydrofolate, reductase, gene, and blood clotting? If you have a single mutation, your risk is slightly higher. If you have the double mutation, it's genuinely higher. So you do need to be careful. You need to take methylfolinic acid, and then you should have aspirin and heparin, in my opinion. Yeah. Another Carly question. What else you got there, buddy?
Oh, I have plenty here.
Did you see the TikTok comment? 10 times, that's insane.
Yeah, it is. It is insane.
Yeah.
10 times is an unbelievable number, I'll be honest.
And someone said, you mean just for funsies?
Yeah, just for funsies.
Yeah.
Just a good old funsies.
Yeah.
I have 2 endometriomas
Oh.
that I didn't have before my second egg retrieval.
Okay.
They are 1.4 centimeters, no symptoms. Should I be worried? Should I remove them? Could they be causing issues with pregnancy?
Well, for sure they can cause issues with getting pregnant, because if you have endometriomas, you have endometriosis by definition, and we know that that cuts your chances down significantly. Should you remove them or not? It's very controversial. My personal opinion, yes, because they only get bigger and get worse and damage your ovaries. So catching them earlier is way better than catching them later. But there is research that supports the fact that removing endometriomas causes damage to your ovaries. I believe those studies are hampered by the surgical technique that's used, because I would tell you that the vast majority of gynecologists do not know how to properly remove an endometrioma without damaging the ovary. But, there are studies that say it will damage your ovaries, so you have to be careful.
My kids still sleep in our room. We have to run to the couch or guest bed after they're asleep.
Do the guests know that?
A whole different vibe, that guest bed.
That's a whole guest bedroom vibe, yeah. Do you call it the red room?
That's a room. I think they can still do it with the kids in the room. You just gotta know how to maneuver. Once the kids fall asleep.
Okay, that was one line I drew early on.
I think if the kids are knocked out.
There were no kids in the room.
I think if the kids are knocked out, I don't think the kids should be in the room in the first place. To me, this is you know what? If they're past waking up 50 times a day,
Yeah.
you move them over.
Even 50 times I put them in.
Right away, eh?
Yeah.
Just park them in the other room.
I punted the kids into their bed. Even if my wife fell asleep with them next to us, I would pick them up and put them in their bed.
You know what? Nothing wrong with that.
No, I love my wife. She's mine. Yeah.
I think there's a line.
I've
got to draw the line.
I'm jealously sharing her with the kitten right now. That's it. Yeah, very jealously, because he loves her.
Hi, both. For women with negative blood types, is there any additional medication required during transfer or early pregnancy?
For different blood types or negative blood types? Does it say negative blood type?
I scrolled. Hold on. Negative.
Just need Rogam in pregnancy. That's it. That's the only difference. You got another chuckle.
I'm just the comments on TikTok. You can see them. They're pretty funny. People thought it was
mine's not
comical.
scrolling at the same rate, so I got to catch up.
Oh, I got to manually scroll. I see.
When I had 2 under 2, what did it say?
No, scroll all the way to the bottom. Go all the way to the bottom.
When I had 2 under 2, sometimes it was once a week. They push us apart. What are my beliefs on SSRIs during pregnancy? They have risks. It increases the risks of respiratory and cardiac malformations. So if you can, you should avoid them. However, we definitely put a huge importance on your mental well-being. And if it is going to jeopardize your mental well-being, you have to speak to your OBGYN and whoever takes care of your psychiatric needs to make sure that you are balancing your mental health versus the risks to the baby. And sometimes we have to side with your mental health. You cannot compromise your mental health because you're pregnant. So it all depends on how you cope when you are off of those meds.
I have one more comment on the intercourse.
Right to your crib you go. See,
right?
That was me.
That's
the kids.
That's the right move.
Yeah.
So
Yeah.
I came to this conclusion because of what I saw about whatever the kids. So I remember one time when I was younger, not much younger, but a bit younger. I had went to Egypt.
Yeah.
And when I was in Egypt, I did like a whole pyramid tour and
cool. Yeah.
the whole tourist thing, right?
Yeah.
On the way there, there's a whole bunch of little tiny houses for people living, and then people were being, hey, come in for tea after we rode the camel or something.
Just strangers.
Well, yeah, and I like to
just pull you in for
I like
tea.
to be like part of the locals. Like I become one with the people. You know what I mean? I try to integrate.
Okay.
So I'm like, yeah. So I go in there. The guy's got like 6 or 7 kids. He's got a little kitchen, little bedroom, and the area, like all one room.
Yeah.
So the only thing I could think of when I saw that setup was how did he make 8 kids in one room? So I said to myself, they're just doing it regardless if the kids are awake or sleeping. That was the only explanation I could come to. So I'm thinking the same thing applies here. You just got to make it happen.
So you were in Egypt to see the pyramids.
Yeah.
You get pulled into a home by a perfect stranger, and the only thing going through your head
That's right.
is how did this guy have 8 kids?
Wonders of the world were overrated to me at that point. All I could think about is how did he do that?
That was your wonder of the world.
That was my wonder of the world. How did you manage to do that?
That is awesome, yeah. I can say that would not be the first thing that went through my head in that situation.
People get caught up in the pyramids. This is the real wonder, man. I'm telling you.
Oh, I think I'm tearing from that. Oh, that's funny.
There you go.
Oh my God.
Here we go. This is a question a little bit more related.
All right.
Medicated versus unmedicated IUIs for someone with endometriosis.
Oh, that's a great question. So the answer is medicated versus unmedicated. If it's pills, it's fine. In particular, I'm kind of a believer in letrozole because it lowers your estrogen levels. So I think that's a good thing. But I'm not a big believer in doing shots because I think it makes your endo worse because your estrogen levels go higher and the stimulation's stronger. So I would be cautious with the shots, but the pills, letrozole is probably a great choice. Yeah. Yeah. Baha. What does it say? Baha. Wait till they're sleeping. Ha. Okay. Yeah.
Does the use of human growth hormone have an adverse effect, endo or adeno?
Not that I've ever seen or am aware of. However, you are supposedly supposed to make more eggs. So if you get your estrogen level higher, that is negatively going to impact endo and adeno, which is why we have a whole endometriosis protocol, which accounts for the damage you're doing from stimulation. So we have a sequential protocol for our endo patients.
Well, I got a hell of a comment / question / something.
Okay.
Yeah, this is a big one.
This is a big one? All right. Yeah.
Hey, Dr. V. I want to start off by saying I think the world of you.
Oh, thank you.
In what you do. I've had friends come to your clinic raving about you.
Oh, wow. Okay.
But that being said, I may have a touchy question.
Okay.
There's been some negative chatter about you in some IVF groups in regards to weight and BMI.
Ah, sure.
I know you only want the best for your patients and want them to be successful first shot.
Right.
This is the only reason holding me back personally to get a referral because what others are saying. So I wanted to clear the air. If our BMI is in the overweight obese range,
right,
and you've been trying to lose weight but were unsuccessful or it's slow, will you make a patient be a certain number to accept them into your clinic?
Well, we certainly don't make anybody wait to be accepted into our clinic regardless of what their weight is. Everyone is welcome here. So I don't know where that rumor is coming from because that's not true. I am very scientific about weight. So the studies are clear on this. If you are under 38, and we just reviewed this a few months ago, actually, from a paper on the show. If you are under 38, and as long as your AMH is reasonable, it is advised that if weight is significant as a factor, so realistically your body mass index is over 35, and certainly if it's over 40, that you should reduce your weight prior to pursuing fertility, because the delay does not compromise your fertility, but proceeding can compromise the pregnancy. So we follow the science. I tell my patients, look, it is in your best interest to lose weight before you start, and that's the best approach to things. If they don't want to, we don't force them to listen to us, because I don't force anybody to do anything. But we recommend that they lose the weight first, and we help them through it, right? So I never tell people, go lose weight and come back. We always give you plans. We connect you with nutritionists. We connect you with exercise plans. We'll help you with medical interventions if we can. So there are lots of ways to kind of help you and facilitate this. So we don't say no, but we do tell patients it is in their best interest to lose weight. And let's be honest about this. It is a very, very sensitive topic. So no matter how gently I try and explain to someone scientifically it's in their best interest, they're going to walk away and say, he was a jerk because he told me that I'm too heavy, which is never what I've done to anybody. But we do tell patients that it is in their best interest for the success of getting pregnant and for the safety of getting pregnant to lose weight if they are under 38 and their BMI is very elevated. If they are over 38, we actually don't make patients wait, because it is in their best interest to proceed. Now, you can also try and make that optimized as well. So, for example, we might go ahead and make embryos, but then ask patients to try during that process to bring their weight down as much as possible, so that when we get to the embryo transfer stage, they are in better shape in order to go ahead and do that. And I'm not a big believer in meds to lose weight, but there is a lot of research on how rapidly things like Ozempic and Saxenda can work. So I'm not convinced yet, but there are some people that should consider that if they don't want to go the surgical route. And certainly the surgical route takes a lot of time. So I think that's a discussion you need to have with an expert in metabolism, like an endocrinologist, and talk to them about whether or not those medical approaches are right for you. So summarize, I never tell anybody what to do. We only offer advice and options. I would never exclude anyone from coming in for therapy, but we do tell patients who have the opportunity to lose weight and make their pregnancy safer to do so before they conceive. Now, in some instances, people have to understand the risks and benefits of their weight before we go ahead. So again, as an example, if you're 40 and your BMI is over 40, like you're 40 years old and your BMI is over 40, you are looking at a 90%, 80 to 90% reduction in success, and your natural pregnancy rate over 40 is probably only 5 to 10% per month. So now you're looking at a 1% chance or less. Does that make sense for anybody? Of course not. So we have to work with those people to bring down their weight. If it makes me a bad guy for trying to help people, I'm actually willing to be labeled a bad guy for that. I'm not doing it to be mean. I'm not doing it to be hurtful. I'm not doing it because I'm fat shaming anyone, because I would never, ever, ever do that to anybody. I'm trying to keep it scientific and help you achieve what you want from me, which is a pregnancy. And in order for me to do that, sometimes I need you to help me. So sometimes that's dieting, sometimes that's exercise, sometimes it's weight loss. And in many instances, last week I've told women to gain weight. So it's not just about optimizing your weight in only one direction. It's not always losing. We have women where we have to tell them gain weight to improve your egg quality and your egg number. Again, I'm willing to take the hit if that makes me a bad guy, because what's important to me is to be honest with my patients and to achieve success for them. And if I can do that by optimizing all of their health, supplements, vitamins, exercise, yoga, meditation, acupuncture, naturopathy, weight gain, weight loss, whatever it takes, I will do whatever it takes to help them. I don't know I'd love to hear back from you guys. Tell me what you think. Let us know if you'd rather hear me tell you the truth, or if you'd rather we just never mention your weight at all because you don't want to know. I'd be keen to hear back from people. Tell us what they think.
I'll let you know what shows up.
Yeah.
When traveling prior to transfer, is Zika still a concern?
Yeah, it's always a concern. So Centers for Disease Control in the U.S. has a great website that used to have a Zika map. I think it's still there, so you can check that before you go, and it tells you where the hotspots are. I appreciate the fact that patient asked the question the way they did.
I think it's a great question.
Yeah.
I think it's a great question.
There's one from TikTok. Was advised I have PCO and high AMH. Had 3 recurrent miscarriages. Any thoughts? Well, theoretically, those two should have nothing to do with one another. Recurrent miscarriage is complicated. It can have to do with a variety of different things. I would need to see you to figure it out. So get a consult and we will take care of you. But it can be genetic, it can be structural, it can be hormonal. It can be related to bad habits in you or your partner. It can be related to sperm quality, infections, immunological problems. There's a laundry list of stuff that can go into recurrent pregnancy loss. So definitely reach out and I'll be happy to figure out which one of those it is.
I'm just trying to find the next one.
This show flew by. Did you notice that?
Yeah, I did notice that for sure.
It really
we had some good commentary today.
Yeah, we did.
Daughter has 1,3AA blast, frozen, no PGT.
Okay.
She's 35 years old.
Sure.
Low AMH.
Okay.
What is your thoughts, please?
Yeah, I mean, a 3AA embryo is a great embryo. It's gorgeous. So it depends on which grading scale, but if it's our grading scale, that would be a beautiful embryo. So yeah, I would have no trouble with transferring that. At 35, she's got a 50-50 chance. It's genetically normal. AA grade embryo, I mean, the chances would be very solid. I'd be super excited for that individual. Does baby aspirin have any risks or only benefits? Everything has risks. Tylenol has risks. So sure, there's bleeding, easy bleeding, bruising, stomach ulcers, stomach erosion, gastritis, all sorts of possible risks from aspirin. How often do those things happen? Rarely if you're taking it properly. There are significant benefits, so I am a believer. We have a really great video on our YouTube channel on aspirin. Watch the video.
Should an IVF pregnancy be induced at 39 weeks? Ours went to 40 plus 5. Is that still safe?
Okay, so in my opinion, no. Your induction for an IVF pregnancies are slightly higher risk for complications. And so because of that, we induce. Why? Because induction of labor at 39 weeks has been proven in a very well done randomized controlled trial to improve the outcomes, including reducing your cesarean section rate with equal satisfaction rates to natural labor later on. So why would you not do something that's got equal satisfaction but is safer? I don't understand the risk the benefit in waiting. It doesn't make sense. And we've got a great, video on that with 150 something thousand views on our YouTube channel. So watch the video. It explains very clearly from the trial called the ARRIVE trial and the follow-up to the ARRIVE trial what the benefits of induction of labor were. I must admit that I have a little bit of a guilty pleasure creeping on the Instagram posts of people that go on there and talk about doing their 43-week delivery, where I go on and say, what's the evidence for the safety of this? And then they all go nuclear and start attacking me. And I actually kind of think it's funny. So those people are making a mistake. They are risking their babies. They are risking themselves, higher risk of preeclampsia, stillbirth complications with zero benefit. And they're all like, oh, your body knows what to do. That's garbage. It's total nonsense. Your body doesn't know what to do. If our bodies knew what to do, we wouldn't have all the diseases that we have. So it's simply not true. Your body does not know what to do. And the fact that you're a woman does not mean your body knew what to do either. It's not like you were inherently designed to spontaneously go into labor at precisely the right time. That is not the case. If that were the case, people wouldn't have stillbirths. So, that whole line of thinking is asinine, actually. It's ridiculous. So there are benefits to being induced, and certainly for our IVF patients, I definitely encourage them to, but we actually share that information with all of our obstetrical patients.
Hi, Dr. Vinti. If you are going for IVF baby number 2,
yeah,
and you got eclampsia the first time,
yeah,
Will you get it again? Are you high risk? Does it impact pregnancy chances for embryo transfer? Number 2.
If your blood pressure has gone back to normal, it doesn't affect chances. You should be on baby aspirin to avoid it, even from before you start your transfer. And no, you are less likely to get it in your subsequent pregnancy than in the first.
FET protocol for someone with longer cycles, normal luteal phase 12 days.
FET protocol for what?
Someone with longer cycles, normal luteal phase 12 days.
Wouldn't change anything. I'd still do my normal protocol. Why would I change it?
I don't know.
Yeah, that doesn't change it. That doesn't change anything.
Why would you change it?
I wouldn't
Great
change
question.
it. Yeah.
When assessing BMI, do you also take the patient's looks into consideration, example, more muscle, or you only go by weight and height?
No, I mean, we take into consideration everything. Bodybuilders have very high BMIs even though they're super lean. It's because muscle's very dense. It weighs more than fat. So, of course, we factor that in. Yeah.
I'm all muscle, to be quite honest.
You are all muscle. Yeah.
I am all muscle.
That's the explanation for your BMI, for sure.
That's right. Hey, Dr. V, what vitamins would you recommend, if any, preparing for an FET, especially if you had implantation failure in the past, endo/fibroids?
Well, I'd probably recommend our endo protocol, but if you just want to know about the vitamins, vitamin D, iron, fish oils, prenatal vitamin, and melatonin, and then the 5 for endo, so resveratrol, NAC, curcumin, coenzyme Q10, and ALA.
Hi, Dr. VNT. Low quality frozen embryo BC and CC at 40 plus means a high risk of miscarriage. You are very funny tonight. 4 times per week with no kids.
We got the full spiel there, right? Yeah, I mean, I can't tell you it's a high risk of miscarriage, but you definitely have some grading issues there, which are going to be concerning for success. And then, yes, of course, miscarriage, because if the placental portion is graded C, that's a high risk for the placenta not to develop properly. And if it doesn't develop properly, the fetus can't. So there are concerns with that. But it doesn't mean it won't work, for sure. And so I think there's always a chance. And, if that's what you've got, that's what you've got. So you have to go with it. The big issue there is going to be, are they genetically normal or not? That's a different story.
How often do polyps come back? I have a polyp removed in June and just had a saline sonogram and found another polyp in the uterus. Is there anything I can do to prevent them coming back?
There's nothing you can do to prevent them from coming back that we know of. If they got all the way down to the base, the same polyp should not come back. But there could be other polyps that develop. So I would want to see the pathology report from your first one to see what it was before I could tell you anything further.
I love this so much. Thank you. Always the truth, they say.
See, it's funny, like, and I genuinely struggle with this, right? So if I tell people that their BMI of 40 is going to increase their risks, I'll rhyme them off for you. It's going to increase your risks of blood clots, miscarriage, failure, 90% reduction in like a FET success. And I need that to echo for people, okay? If I've got an 82% success rate with a euploid embryo pretty much across all the ages right now, and I take that and I knock it down by 90%, you have an 8% chance of success. So we went from 88. Okay, so does that make sense for anybody? Of course it doesn't make sense for anybody. It's illogical. It's irrational. No one can do that math and tell me, yes, you shouldn't tell me to lose weight because I want my 8% chance of success. But no matter how I phrase it, and I've tried everything, it's very, very, very difficult to get everybody to be happy with what you're telling them, because many people struggle with their weight. I get it. It's very often a lifelong struggle. I respect that for sure. And they either don't have the time or the ability or the resources or whatever it is, even the biology, to be able to affect significant changes in their weight. So when you're running into that problem, we're also running into the problem of the fact that those patients don't want to hear that they need to lose weight. And I struggle with this. I don't think there's a right answer. Like, I could ignore it and not tell anybody and everybody be happy with me, but then I'm just like everybody else. And I don't want to be like everybody else. I want to tell people the truth because they deserve the truth. It's not always easy hearing the truth, but I think it's important to tell people the truth. But, again, I'm open to your feedback. I would love to hear a huge, discussion in the community. And Tarek and I are going to start a blog on the website. I'm going to pin them down for this weekend to get that done. So maybe that'll be our first blog topic. Jump on the website, drvictory.com. Let us know what your thoughts are. Should we be telling people that they should lose weight before they do it? All the risks are, DVT, cesarean section complications, ICU admission. If your BMI is over 40, your baby, after it's born, has a 3-fold higher risk of dying. After it's born. So there are risks involved with the birth of children or the pregnancy of children when your body mass index is high. It doesn't mean you've done something wrong. You're not guilty. It's not about that. It's about optimizing your chances to achieve what you are asking me to achieve for you. So you're coming to me asking me to get you a pregnancy. I need the tools to do that. And one of those tools is you. So if I need the tool to be sharpened, I need the tool to be sharpened to do what I need to do.
Hello T, saw you on an older video, you handsome devil.
Figures you'd read that one.
My goodness.
Yeah, he was crawling across the screen.
Yeah, there's moments. There's
a couple.
This is a dedicated viewer.
You're not hard to find.
I'm not. If you look.
If they look, they can find you. Yeah, for sure.
Any hope for premenopause, donor or natural?
Huh? I don't get it. Any hope for premenopause, donor or natural? Well, your chances with donor are going to be way higher, but there is a chance with natural. And again, the stuff we talked about before, PRP, human growth hormone, DHEA, there are ways to attempt to rejuvenate the ovaries for whatever that's worth. It really becomes more of a financial question than a medical one. So if you've got the money and the resources to try a few times, we've got ways to help you. Are they going to work? We don't know. But it's worth trying if you can afford it. If you cannot afford it, then you need the discussion of what the chances are, right? So in a premenopausal state, you're probably looking at a less than 10%, 15% chance with IVF versus, almost 100% chance with the donor if everything else is okay.
902.
It's like huge, eh? I keep seeing like a bajillion people.
Yeah, everything is
it's off the charts.
Yeah, it's pretty busy.
Yeah, it is. I've got a couple of TikTokers.
Sure.
What size should follicles be on day 7 with gonal F75? It depends. It's just so dependent on your age, your body mass index, your AMH level, all of that stuff. But by day 7, you want to see 10s, 12s in that range, generally speaking. Do you have other ones here? Because I'm scrolling through. We did the BMI. What are the chances of a second miscarriage? Whoa, I don't know what the first part of that question was. If you've had one miscarriage, your chance of a second miscarriage is not significantly increased. So in the background, 1 in 6 pregnancies miscarry. So that's 17.6%. So you're at the same risk approximately. But if you have a second miscarriage, your risk of a third starts going up.
Best protocol for FET stage 3 endo.
That's the video we got to do. So just for FET?
That's what it says, for FET.
3 months of Lupron and letrozole. Letrozole extended for 5 more days. Do high-dose progesterone. Try and avoid any estrogen, but if you need some, 1 milligram at a time, no more than that. Like 1 to 2 maximum, but go step by step. Use the 5 endo supplements we've mentioned on the show several times already. And then go for high-dose progesterone, both vaginal and injectable. Make sure they're measuring your levels. Immune protocol, so steroids, intralipids, stuff like that.
Had an excision surgery almost a year ago, stage 3 with DIE. Symptoms are back. Should I consider another surgery before TTC?
Oh, that's a great question. Depends on your age, but I'd probably start by just trying for a few months first. Maybe book your surgery for a few months out and then try for a few months first. Then if it works, it works. If it doesn't work, your surgery's already booked, so you didn't lose any time.
Hello. Thoughts on day 7 embryos? I have one that stopped growing on day 3, started again on day 5, reached blast on day 7, frozen 4 BC. Thoughts? What would cause 2 days of no growth?
I've actually literally never heard of that before. But I think the bigger issue would be what's a day 7 chance like? So we know that they're much higher risk of being aneuploid, not genetically normal. And we know that the chance of success, even when they are, is drastically reduced. It's less than 15% according to the research. So it's a possibility, but it's a bit of a stretch, unfortunately.
Hi, Dr. Rahi. Can you please provide the FET protocol for endometriosis?
I did.
Can a hysteroscopy clear blocked fallopian tubes?
No. Absolutely no. Not at all.
What do you recommend for women who are 40 with a low AMH and a high FSH?
DHEA, human growth hormone, testosterone priming, no birth control. For sure, no birth control, no estrogen priming. PRP if it's right for you, so talk to your doctor about that. Lots of vitamins, supplements, naturopathy, acupuncture, and then I still like the microdose flare protocol. I'm an old soul in that way. I think it's a great protocol still to this day, but we can't get it anymore, so it's super hard to get, and I think I'm probably single-handedly depleting the U.S. supply. So we're actually sending our patients to the U.S. to pick up their meds because I'm licensed there, so I can write prescriptions. So that's a great approach. Otherwise, I don't pound people with medications when they have weak ovaries, because even when they have high doses of meds, they still end up making the same amount of eggs. So we actually give them much more modest doses, like, medium or even low doses of meds. Wind it down. One more Tarek's Terminal.
Okay.
We're at almost 9:10.
Challenge.
Yeah, 9:07.
I accept the challenge.
Wifey will kill me. I gotta be alive for the next show.
Of course, very important. I can't do it without you. Let me see here. Maybe terminal question. Hey. Okay. Hi, Dr. V. What level do you usually like to see progesterone levels at or prior to FET if on endo protocol? I'm worried 0.5 mils of PIO won't be enough.
So in US units, roughly 45, in Canadian, around 130 to 150. So I got to end the show with this. Someone, I won't get into specifics for privacy reasons, but I've got my Apple Watch on. So someone very near and dear to our family just texted me, who just had a baby, and I took care of them. Very, very nice young couple, very young. And they've got a beautiful little baby that I delivered. And she said, "We love watching you every week on IG while she eats and gets ready for the night."
There we go.
And this is a very young baby. And so thank you for watching. I love you all. Great show. That was a lot of fun. A lot of good laughs. If I ever visit Egypt, I definitely will not be thinking guy.
You'd be surprised what pops into your mind when you're in the desert, man.
I will see you guys next week. Hopefully there'll be a good study out that we can review. That would be cool. Otherwise, we will come back with lots of information. Watch for our new videos, myths about birth control, and one part that's not such a myth about cancer risks with birth control. So I'll share that with you too. Watch for a video on our endo protocol. I know that one will be super controversial. And watch for my rant, because I'm going to put out a rant video and see how that does. Hope you guys have a great night. If we didn't get to your questions, I'm sorry. There's only so many I can answer in an hour and 10 minutes. We love you all. Thank you to our European group, especially. I mean, huge round of applause for you guys for staying up from, I guess, 2 to 3 in the morning to watch this show. We never thought it would be that huge, but we are super, super pleased that we can be of service. So very excited to see you guys again. If there's anyone I didn't get to that's desperate for answers, I do tend to answer most of the questions on Instagram. So just DM me and I'll get to as many as I can. Have a great night, guys. We will talk again soon.